Yes. Do you all go to the harbor and see Singapore famous fish or lionfish or something? Haven't you been to that very big famous hotel that have the bridge across? Yeah. You can look down there. What is that called?
Marina Bay.
Yeah, Marina Bay. But that's not where this North Korean president stayed, right? Was that there or that's not? You know when Kim Jong-un, he was here for that summit, I wonder where he stayed. And the latest question still is that who paid for his visit when he was here? That was the question that's still the question right now. So, okay. So I have the honor pleasure to share with you three topics this morning. And with the first one we have to do now with systemic disease that has the eye involved with it. So that's really very important for us based on what we have been discussing so far. After all, that is the main concept when we discuss about uveitis and a lot of these ocular inflammatory diseases here. So when you think of systemic with ocular manifestation, yes, certainly many of us will be thinking of aspects like uveitis entity. But one need to remember that, like we alluded to yesterday, some of them are very much non-inflammatory, at least overall and common. For example, when you talk about hypertensive retinopathy, yesterday you've heard some of the discussion in there, that is clearly a systemic disease that have eye manifestation. And same thing with diabetes as well. On the other hand, you also have infectious uveitis that have systemic origin. For example, tuberculosis is a very famous one for that. Same thing aspect from there. You can have Lyme disease. You can also have, for example, syphilis disease that have systemic disease that also have ocular manifestation. So when you think of that, don't just think only of uveitis cases, but think of other aspects of it as well. But on the other hand, there's non-infectious uveitis, and that's the one that we are wanting to discuss this morning. And now we're focusing on this group of disease that are considered non-infectious uveitis that has to do with systemic disease. Yesterday, when I talk about retinal vasculitis, one of my categories say that when you look at diseases, you divide into two different groups, infectious and then non-infectious with systemic disease and non-infectious without systemic disease. So this is the group that non-infectious with systemic disease. And there's a number of them that we can see in the listed here. For this presentation, I'd like to share with you some of the experience I've had with 6 of them. And those are the sarcoid, lupus, Behçet, Wagner, rheumatoid arthritis, and relapsing polychondritis. So that's what we can try to go over. Starting out with SLE, this is obviously one of the very most well-known. There was a case that we presented yesterday to share with you. We mentioned that the American College of Rheumatology has set up 11 criteria for the diagnosis of lupus. In order to have that, you need at least 4 of them. And this criteria including things from renal disease to blood work testing like ANA and double-stranded DNA positivity. So based on that, you would then make the diagnosis, but you need 4 of that. And unfortunately, as we mentioned yesterday, the eye is not one of those criteria. So at times it will be difficult for us to discuss with the rheumatologist to make sure that they're also in agreement with us with this aspect. But certainly the laboratory testing can be helpful. And when you do that, then you should get both the ANA as well as the double-stranded DNA. So again, if you are suspecting to have a case of SLE, then make sure you have both the ANA and the double-stranded DNA in that. So after many decades, we still don't have a very clear understanding of how SLE to begin with. However, we do know that there's a lot of production of these autoantibodies and also immune complexes, and thereby the inability to suppress them. Because of these circulating immune complexes, that's why it causes a problem. So how do we know there's circulating immune complexes in that? So first, there are testing that we do to check for that. But second, what is plasmapheresis? Plasmapheresis is a system whereby you basically clean out your blood and then you put it back in. So that is the one type of treatment that we do for advanced cases of lupus, including lupus of the eye. When you cannot control it well enough, that's one of the last steps that I take is to offer a patient plasmapheresis and arrange for that. So basically, you wash out the blood, remove all the complexes, and then infuse it in again. So that's how you can understand a little bit more. For lupus, for systemic manifestation, you definitely can have a patient that can come in with fatigue, fever, weight loss, and a number of organs that can be involved with that. Certainly, this is a famous butterfly flash that many of us have seen in our exam, in our board thing. And when you see something like that, it's help you, but it's not a very common sign. I mean, you see it, but you don't always have all your lupus patients coming in with that sign for you. When you do, you can definitely get help. As you can see here, it has CNS, it has cardiac, renal, dermatologic, and pulmonary. Everything like that helps you. When I was an intern many decades ago, one of the cases that we admit to the Massachusetts General Hospital was a patient coming with infusion like this and administered the CCU and woke her up, and how she turned out to have lupus in this aspect as well. So pleural effusion and pericardial fluid can be a very good manifestation of that disease as well. What about the ocular manifestation of lupus? So certainly, what is the most common ocular manifestation of lupus? Is it retinopathy? No, it's actually this aspect with the keratoconjunctival sicca, dry eye. So that is the part of this. This is sometimes that you in a differential diagnosis, when you consider a patient with keratoconjunctival sicca, they look at either Sjogren's syndrome or a lupus syndrome, that type of thing. So this is part of that. That is actually the most common manifestation of lupus, ocular manifestation of lupus in there. Lupus retinopathy is certainly a possibility, and this was a case that we presented yesterday in this aspect, and this can include various aspects. Can start with just the cotton wool spot that we have. It can go on to have hemorrhage, the vasculitis, the vein and artery occlusion, and that. And then choroidopathy is another aspect from there. So sometimes you do not have retinopathy yet, but you present first with choroidopathy, and it leads to, for example, exudative retinal detachment from the choroid disease and this aspect there. So that's on the differential diagnosis as well. And then the last line, the bottom there, the last figure, that is when you have optic nerve involvement. In addition to the optic neuritis, you can have the various other nerves like third nerve, palsy, and things like that you can experience from there. So again, just as with the body where you have multiple organ involvement, for lupus in the eye, you also have multiple from both the anterior to posterior segment aspect. Lupus patients who develop ocular disease are at risk for extraocular disease, even if the rheumatologist find the patient to be in remission. So this is a very important statement. If you're working in a hospital and you're caring for the eye for a patient with this, and let's say the patient coming in to see you, if the patient have already a diagnosis of lupus, and let's say the patient is on 2 milligrams of hydroxychloroquine, Plaquenil to maintain, and the rheumatologist said, oh, the lupus has been stable for years. But now when you see of this nature, when you look at the eye and you find the evidence that there's active disease in the eye that consistent with lupus, our mission then is to convince the rheumatologist that this is not a stable disease, and that is the patient needs to be treated more aggressively, because we know that once the eye is involved, the next organ that we go is the brain. So therefore, you have to do quite a bit of discussion. If you have a good rheumatologist, he or she will agree with you, but sometimes they are insisting that the patient is stable, but that's not the case. We have looked at a number of this, and when the eye is involved, that means that the next organ to fail will be the brain. So we need to convince them that the patient is not stable. And with this error, hopefully that they begin to notice it, but that is a very important message, because the eye is not one of those 11 criteria. So sometimes the rheumatologists forget that there's an eye there, so they don't believe that what we say. And so we have to convince them to do that. And I have done many, many times, and when I was intern resident in Boston, that's what we try to convince our doing there, and then finally we try to make some headway from there. So this picture on the top is a case of the choroidopathy there. So this is basically, the retina cell is fine, but there's a choroid involved, leading to an exudative RD that you have in this aspect from there. And so retinopathy and choroidopathy in the series that we published very much indicate that the existence of it. When you have choroidopathy, it's often that you have also nephropathy, you also have CNS disease as well. So that's very much, the eyes are very good, we call barometer, basically a sensitive point for us to then use that to detect other diseases. So that's very important that we follow that aspect. So that's the cases of various number of increased introduction to SLE. You will see that across your career, it is not a very uncommon disease, so you will see that. And the question is to recognize if the eye is involved, then we need to move on to move forward. Now, the next entity that we're going to go into, any question on lupus so far? Okay, so and obviously there's the aspect of you used to make diagnosis based on systemic lupus, but if you have just localized lupus, one of the best way to do it is to do a biopsy. So work with dermatology, get them to do the biopsy and do it quickly, early enough. That will help you make the process. The next
question. So lupus as a cause of optic neuritis, is that common at all?
It's the cause of optic neuritis, but it's optic neuritis with something else. So that's a good point. If you just have an isolated optic neuritis, the problem is that is quite rare. So usually present with an optic neuritis, but let's just say also with a choroidal detachment from kind other disease.
Right.
Yes.
So the next question is, if I have a patient with isolated optic neuritis, is it fair for me to say I'll just not screen for lupus for ANA? Because in my institution, we usually send for ANA for optic neuritis.
That's correct. So I don't think that unless they have other sign with it, if we have an optic neuritis alone, I would look, I mean, obviously we would do very workup based on symptoms, but that is much more, as you know already, that's much more associated with MS and other things rather than with lupus. And usually with that, they usually present, like say, is rather than just optic neuritis only. It's usually optic neuritis in conjunction with something else.
Okay.
That's like there. So, any question? Great point in there. So just please ask questions. This is the whole reason why it's also keep the unit very small, because we want to make sure that you feel comfortable. Everything you stay in, just like Las Vegas, whatever happened in Singapore, stay over here. We don't go back to various places. And here. So the next entity that we have is the granulomatosis with polyangiitis. So GPA, so former name of Wagner, this aspect from there. So this is have also another condition that have multi-organ and potentially lethal vascular diseases in this aspect. And this is one of the diseases where men and women are equally affected. Most of the time in a lot of inflammatory disease, the women are more affected, but this is one of the few that have very much equal distribution. The presentation of it can be quite protean as well. The histopathology of the structure is very important aspect from there. And one of the things is that you can present, not only internally, but also external disease of the eye, we can see from here with aspect here. The C anchor is a very important marker that is positive in 95% of the patient. So we know that when we look for anchor, we either look for C anchor or P anchor. What's P anchor for? That's correct. So that's PAN in there. So that's the clear definition. So when you ask for that, just make sure it's differentiated out carefully from that. Systemic manifestation of the Wagner is very important. What is usually, what is the cause of lethality in patient with Wagner? What organ fail? So Wagner is usually, the kidney is the one, the aspect from that. That's the one that we really also, just like lupus, that usually lead to the mortality of the patient in there. The respiratory aspect is also very important as well from this there. And what you see in there is this focal necrotizing glomerulonephritis, that's what you see from this aspect. And so that's what we want to see in the biopsy in that there. But usually it's thought out when you look for the patient with GPA, one of the things when you suspect of this is what testing for we usually at ophthalmologists that we order in addition to C anchor if we suspect GPA. Besides the C of anchor, what other things do we look for? Another word in the questionnaire that you look as a patient, what are you looking for in the sign? Sinus disease, right? So that's one thing. Sinus disease, if you look in this aspect, they have the chronic sinus disease. Second, you may not detect, but it's one of the tests that I always order would be a UA, because before you should begin to see some blood or some cast in the urinalysis if you're going to suspect the GPA in there. So that should be part of that. If you go along that route, I'm not proposing that we do that in other patients, but if you feel that patient have enough finding, let's say with vasculitis, with evidence in the eye that suggests that, then part of that, before you refer the patient to the rheumatologist, and I always ask our resident fellow, the rheumatologists are just like us, they went to medical school the same way we do, so we just have to make sure that when you ask them a question, don't just send them the patient and say, work it up. You do your own thinking first, and you say what part of this will be passive, and you help them. That way, you yourself learn something from it, and they themselves know how serious we are in asking the question. So if you already asked the anchor, you already asked for sinus film, and you already asked for the UA, by the time they have it there, they can help us some more, but at least you're thinking along that pathway to do that part. Okay. So the ocular manifestation of this, so the first sign of the eye disease for the GPA is actually orbital disease. It's not the retina. It's not the thing that a lot of the time that you have in this aspect. Scleritis is another aspect of this, but usually that's what retina presents is orbital disease here. This is a child that I saw. She is from Mexico. That when she presented. So in a child with unilateral proptosis like this, we worry about a number of things. One of which obviously is rhabdo, that myosarcoma that can occur in a child like this. But in this particular case, it's very concerning. And when you do the imaging, you also see a lot of infiltration of this aspect from there. So this is present with that. And certainly, yes, as part of the workup, you want to make sure you don't miss any malignancy of that type. But when you carefully look at it again and you do the biopsy, and especially if you see some ocular involvement like this, then the diagnosis of GPA should be on the differential diagnosis for that. So orbital disease and scleritis are the common manifestation of retina, not necessarily retinal disease, but those two. If the posterior segment is involved, it would be the retinal vasculitis that we have there. Now, there's an entity that in uveitis we have a number of situations where, for example, you have the eye finding that very much consistent with this, but you don't necessarily see the whole systemic disease yet. And then within 3 to 5 years, if not, they can evolve into that. So there's an entity that called limited GPA, that you can look at the literature, the publication on this, the limited GPA that evolved into systemic GPA and then with positive C anchor. So if you suspect yourself as an ophthalmologist that this may be looking like that, that is fine. There's no need to really fight it and say, make sure you make the diagnosis right away. You just say, you have very much consistent data, consistent with X disease or Y disease. We would treat you as short, but we continue to follow. So in uveitis, as you know, we don't just stop evaluation once. You do it as much as you can at the time. If it's negative, if it's non-revealing, no big deal. You follow the patient, you treat him or her as much as you can, and then keep that in mind. Mark on your mind, mark on your chart, mark on whatever file that this patient may need for the evaluation, especially if you something arrive, in which case you recheck it again for the patient, and that helps. And that's definitely the so-called limited retina that we can have. So that's retina. So that's number 2. The third one is sarcoid. So sarcoid, as we discussed yesterday, is a very common condition that can occur in a number of cases, and is still the mystery as to how sarcoid occurred. This is a multi-organ granulomatous disorder of unknown etiology. The ocular involvement is quite common. It's about 50 to 25% of the patient with sarcoid, and it has a worldwide distribution in there. Both pretty much throughout the world very much, and all ethnic background from Caucasian to Asian to African American, we all have this potential can have that aspect from here. Female is more common than male, and this is a disease that of the early onset. So yesterday, Professor Gupta mentioned this aspect. You think of the patient, you see what type of condition that can occur, whether it's early or late. For example, birdshot, for example. Birdshot is more in the Western world, but birdshot is the condition that we don't see, for example, in 20 years old in general. When 20 years old patient we present with that, that's more of a patient of the elderly group. So therefore, if you have a patient, if you're going to consider that, it usually meet within those criteria. Whereas sarcoid here in this case is very much all different ages. They can also be the younger group as well. And so when you see sarcoid like this, one of the classic significant thing would be this granuloma thing here. Now, of course, if we show a picture like this, and you on your oral board, when it asks you on a differential diagnosis, so in addition to sarcoid, what other thing can go here? I'm sorry? Syphilis. A little bit less when you see granuloma like this. What? TB. So obviously TB, that's another big deal here. So if you see a case like this with granuloma, with cell in there, with some of this thing, you have to be on that. So you keep in mind between non-infectious and infectious here. So yes, sarcoid is one, but TB is definitely on a different diagnosis here of that aspect from there. So you keep that in there. So to help with the sarcoid, there's several studies do it. Certainly all of us, we usually start with the basic chest x-ray to look for the hyenopathy in this aspect, and then from that the hilar disease, you can consider whether it's more consistent with sarcoid or more consistent with TB or not, but that we do. So then you proceed with doing a biopsy, which is important, and this is where you can see the granulomatous lesion from there. And you can do various types of biopsy. You can do the lung, you can do the lymph node, you can do the liver, you can do the conjunctival biopsy as well if you see enough the finding. But certainly it's oftentimes good to have that. You also see in the literature whether people can combine as well. Sometimes people use gallium scan, people use bio-CT, there's a number of things. So if your suspicion is high and you see most of the things is high, please proceed to do as much as you can. Chest x-ray alone cannot do that, always do that. You do as a screening, but you definitely cannot say the chest x-ray is negative. The other thing is this angiotensin-converted enzyme level, the ACE level here. So this reflects the total body granuloma aspect from there, right? So what situation may give you a false negative of ACE? When may you suspect that the ACE may be falsely negative? If you're on ACE inhibitor, exactly. So many of these patients, especially elderly patients, they have high blood pressure. So ACE inhibitor is a very good medication for hypertensive. So watch out for that. So if you can test order, just keep in mind what are some of the limitations that you have. So if the patient come back with a low level of ACE and you suspect very highly, look for the list and see if that makes sense or not. And then you can combine, one of the studies coming out from Cleveland in the past has shown that if you can look at the combination of ACE level and gallium scan, you pretty much can make the diagnosis of over 90% of the patient to do that. And so especially in this aspect. But keep sarcoid in mind. I say sarcoid is a surface or thing that you can always put in your differential diagnosis and you'll be fine with that. The manifestation of sarcoid is pulmonary is the most common one aspect from here, and you can see from here. On the other hand, you also can have some dermatologic lesion from this aspect. Erythema nodosum is the type of lesion that you see in this stage, for example, in this case. And then you also have the papular rashes and the black on the skin that you see in this African American patient from Baltimore here, that you can see from there. And so the manifestation of this can have multiple parts. Neurosarcoid is very, very common indeed, especially if the eye is involved, so that you keep that in mind. It can present with facial palsy, it can present with papillary edema that, as alluded to, can usually it can look like optic inflammation or optic neuritis, but usually it's come with something else, with facial palsy, with other aspects as well, meningitis, endocrine disorder. And then of course you have the musculoskeletal condition that you can see from there. The ocular manifestation of this is quite protein and has multiple parts. Anterior segment finding, you can definitely see granulomatous, uveitis, anterior segment. From there you can see KP, you can see interstitial keratitis, you can see a number of things. For the posterior segment, the common thing you can hear about the vascular involvement, like yesterday when we talked about periphlebitis, wax stripping, that's something that you see in the back. But you also can see, for example, in this case, with subretinal infiltration of the inflammatory material as well. From there, you see retinal revascularization after chronic cases. You also see optic nerve involvement, very much quite protein. And then the orbital, that's the gland that's involved. So that's another site that sometimes you will see that our colleague from plastic will biopsy that lacrimal gland if there's not enough suspicion for that. It is important to note that the uveitis is quite common with this. Is a graph here about more than 2/3 of the patient will suffer vision of 20/70 or worse if we let it go. So this is commonly involved the eye, and this can definitely lead to significant visual loss if we don't treat it properly. This is another patient that started out with a small granuloma from this aspect, and then on the periphery you can see the deposit just along the blood vessel here. You can see from there. So the quite protein manifestation, keep that in mind because it's quite diverse. And in the field of uveitis, this is a very common disease that we see quite often from here. They have the course of disease go from both an acute and also a chronic. So you try to treat the patient, you try to treat attack, and then you maintain the patient on a certain dose of immunomodulatory therapy to keep the control of the disease under control. The mortality is 3 to 5%, so it's not small. But it usually when the patient is not properly treated and if the patient has neurosarcoid, that's very important. This is the case that I do remember quite vividly. This is the case when I was in Baltimore here. So this patient is known to have sarcoid, and we've been maintaining the patient very much on the dose of methotrexate to maintain the patient, and she was on, I believe, about 10 milligrams of methotrexate weekly, with methotrexate being found with very good evidence. I was in the OR when the when the nurse say the patient come into the Wilmer Eye Hospital, eyes Institute, like John Hopkins, have an ER, directly to ER to the eyes. The patient walk right in, significant visual loss. So from the OR, I asked the resident to please obtain a visual field. So this is what the visual field show. Okay, what has happened? I'm sorry? Auditory occlusion. So for auditory occlusion, you see now that's one possibility. But in the case of sarcoid, what is likely that just happened? And if I tell you, this is a week later. So this is one of the presentation, a week later, that's how she looked. What's just happened? Yes, so here's the case where the optic nerve is involved here. So she has acute attack basically of a optic nerve inflammation. So what would you do from the top picture to get to the bottom picture? What did I do? IV steroids. So exactly, this is a case where you treat aggressively with IV metoprolol because you look at the situation, you look at inside the eye, and the patient has a known history of sarcoid. So yes, you consider other things, but you say, what could happen easily? So after I get out of the wall, I saw the field and I look at the nerve, so that's why I say, okay, immediately admit the patient, give her the 3-day course of IV metoprolol, and then follow that. And a week later, she come back just much involvement already. So look at this type of thing, and this type of cases will stay with you forever because you learn a lot from them, and you will see from there. But think of that there. The arterial occlusion is certainly possible, but that is the case of when you look inside the eye that your colleague just mentioned in there, you can see a certain aspect of that. You may see the vessel, you may see the embolus, you may see for a case of CRO. But this is the case where the optic nerve is involved, and it's definitely, if you treat it fast enough. Now, if you don't treat this, after a while, the amount of the nerve will improve, but then the nerve become atrophic, and so the patient will lose the vision. So this is the type of cases where you need acute intervention, and you do so very quickly so that you could do that from there. So,
yes. Statistics as to whether this sarcoid related optic neuritis is more likely papillitis or retrovalvular optic neuritis.
So in this case, so that's a good point. So in this case is papillitis that involved this because you see the nervous cell. But he raised a good point. What happened if it's a retrobulbar? So if I suspect this is a retrobulbar and I cannot see, what do I do? Scan. What type of scan?
MRI.
But that's too expensive first there. What else do you do first? In your clinic, you don't have an MRI waiting yet. But you have a B scan there, right? You look at the B scan. The B scan can also show swelling. And nowadays, even the B scan, what else can you do? You look at OCT of the optic nerve, and you look at retrobulbar laser too. So yes, MRI, perfect answer to do that. But that in Singapore, they're very rich, so they go to the MRI, they give them different thing. But before that, you can do in your clinic, you can do an ultrasound, you can see some that. I'm not saying that 100% accuracy, but they give you some idea first for that aspect. Yes, sir.
Can I just ask, for this case of neurosarcoid, did you do an LP to confirm that it was neurosarcoid?
So this is depend how comfortable you are with your thing. So this is the well-known patient. That is that patient before that. I just showed you the facial. This is that patient. That's her. Okay. So I know her. This is a known patient of mine. So I know the situation. So I based on that direction. But you're correct. If this is coming new, I would not. So let's say this is the first time you see the patient. I would not do what I just did because I need to work up the patient. So then you would then work up. So I would probably do the LP after I do the imaging. So in which case I will get an MRI and to do that. And if I don't see anything in there and my suspicion is still high, and for example, malignant infiltration, for example, is possible too, then I would do a lumbar puncture. But that part of the thing, once I go down the aspect. In this case, I say I did not do much further evaluation because I know the patient and I look at the optic nerve and I say, this is likely the cause. So I say, yes, if it doesn't improve, then, but at this moment, I thought the treatment was very critical to get as fast as possible.
The reason why I asked is because we had a similar case, but bilateral neurosarcoid. And what happened was that when we did the LP, we found that aside from the protein in the CSF, but there was also very high intracranial pressure. It was like in its high 20s, 28, 29. And after treatment, the ICP was still high. So we were struggling with whether we should treat the high ICP as a form of secondary IIH, because initially the patient presented to the neuro-ophthalmologist. So in the end, we began the patient overdiagnosed as well, and we were just we're not certain whether that may help in the long run, but it's just something that.
I think that definitely is possible too. So yes, that's clearly the case as well too. So in that case, could it be in the most like a secondary pseudotumor where you have the optic nerve involvement in there? In which case, our colleague mentioned there, you can either use the CAI common antigen inhibitor, or sometimes you may need to do sequential LP, to bring the pressure down. But that's definitely the case. I would, you're very correct. So if we did not see improvement in here, that part of the step in there. But of course, you see this patient, you treat the patient, and then a few days later, right after the intravenous course, you ask the patient how he or she feel about it. If they continue to show improvement, you let go. If you absolutely see no changes at all, then by all means, do proceed further to do that. So that's very appropriate. It's a very good point. Any other question?
So earlier in the slides, you said that one of the manifestations of sarcoid is that you get capillary edema. So what is the mechanism of?
So you just went in the so that would be the suspected process would be that the inflammatory cells are present that then cause enough of a blockage or a buildup of the pressure around the optic nerve from there. So if that would actually be the presence of, because to get in this aspect, the intracranial pressure has to be high enough to cause that. So what caused increased intracranial hypertension? In this aspect, they believe that this is a mass effect from the inflammatory cell that's present. Very good question. Just think of that. Again, keep your mind fluidly. So whatever that you think, what you can do acutely at that process. Well, my lesson throughout my career, my life is that what can you do that day, that night, that give the patient the best chance to not go into danger? For example, if you have a case that you suspect endophthalmitis for whatever reason, we don't sit and debate what type of organism it is. You say, okay, this is like the case. If I miss this, the vision can go down because the ret only have a few hours to recover and so on, and not being, So you say, what is the thing that I can do that save that, and then I can work up further. If I miss this, what will be the consequences of this? And as long as your mind consciously say that, and you think about it, you think that you do the best for the patient at that moment, that's fine. You may not have anything yet. If you suspect that it's an endophthalmitis, no big deal to give antibiotics in the eye first before you start debating and think. Obviously, you can get some fluid out to do the culture, but do the thing that if you miss, what happened within 24 hours? That the disease won't get worse. And if you keep that in mind, you always put the patient's best interest first, then you should be fine. But ask yourself, if I miss this, if I miss tonight, if I don't do certain thing, what happened tomorrow? And then from there you say, okay, if I don't think this is the case, or that you think that that's the case, do the case. And so that's the point that to anything that many of the things we do, if you ask that question, you should be very good track there. The fourth one we're going to cover is rheumatoid arthritis. This is obviously very, very common in here. And what's the most common ocular manifestation of RA? I'm sorry? Remind me again? No, that's for lupus. So that's the aspect from there. It's common aspect from there, but you see the dry eye from this aspect from there, but what's the one that we really have to be worried about? Scleritis, right? So that's the part from there. So you will see in this aspect from there that you will see from there. That's how patients usually go. And also the sclera is also a very good marker of the disease too from here. This is a classic picture that we see, and this is beautiful. We see that nowadays with a lot of the biologics, a lot of patients can get away from this, but this is a common part that we will see from here, from the patient. And this is something that you can diagnose from this aspect. Does rheumatoid arthritis present with anterior uveitis? So the answer, at least in my career, is no. I myself have never seen that as an isolated finding of rheumatoid arthritis present solely at anterior uveitis. And this is one of the questions I tried to point out to discuss with our rheumatologists and to many of the colleagues that work up. I do not know why many colleagues test for rheumatoid factor. First of all, I don't know what to use with rheumatoid factor. But second, why would a patient with non-granulomatous, unilateral or bilateral uveitis get worked up and have rheumatoid factor tested? So that's one thing that I don't know and I don't see. So ask yourself, you ever come with a case of rheumatoid arthritis that just present only with anterior uveitis. So that's we don't see often. So that's the thing. So therefore, if you have a patient coming in with just that non-granulomatous anterior uveitis, certainly anything is possible, but RA should be very, very, very low on your list because we usually don't see that in isolated fraction. This is a condition that have more female than male, obviously, usually presented in the 6th or 7th decade because this is a disease of elderly patient. Here, this aspect is the autoantibody that directs against the site of immunoglobulin in this aspect. So this is probably one of the reasons why people test for RF, but that usually already have joint manifestation, have other things that you can see. Without them, those things won't be so helpful. And this is another one where you have immune complex deposition from this. The systemic manifestation here can be symmetrical, could be asymmetrical, it's insidious there, and has vasculitis of all sides of the vessel. Patients have this nodule in the extremity, and they also complain of malaise, loss of appetite, and so on with this aspect. Now, the ocular manifestation, certainly scleritis is probably the most common ocular manifestation that's associated with RA in here. About up to 6% of the patient with RA will have scleritis aspect, and the other way around is that 30% of patients with scleritis would then eventually diagnosed with RA in there. So that can be the earlier manifestation of the RA is with the eye and then move on to develop the joint disease. So this is a sectoral nodular scleritis that we can see from here, and it's very helpful when you see this aspect. So we see anything from that to up to this point. So the top one, you see, that's the focal nodular scleritis. The bottom one is more of the case of scleromalacia perforans that we do in there, even though it looked not angry, it was actually very dangerous because we know that this can perforate very soon. So this is a case where you need very aggressive. And this is also the case where you also have a very aggressive need treatment goal with this aspect. This is the case that we saw yesterday that we as aspect from here, and this is a case that we think that's very helpful to look at because this is the diagnosis of Behçet. So that now move ourselves into the fifth disease I want to discuss before. Before that, any question on rheumatoid arthritis? Again, the cases of the eye that we seem to have scleritis, be alert and be very communicative with the rheumatologist. Once again, if the eyes is involved, that means the systemic disease is not under well control yet, and they need to either day or week, if you manage the patient yourself, need to increase in the treatment because that helped overall with the mortality. So the rheumatologists have done studies to show that if the eye is not well controlled and they use various markers, then the overall mortality rate of patient with eye actually increase with that. So therefore, using the eye as a parameter. If you don't see the eye, if you see the eye finding, communicate with your rheumatologist and say that you really need to increase this aspect from there. And now with many biologics available, you have a number of options that you can treat that will help with eyes as well. Behçet disease here. Anyone here have not seen cases of Behçet? So great, so many of you have seen that, right? Yes? Okay, so this is very good. This is a condition that is much more common in this part of the country rather than in the US. In the US, we rarely see the Behçet. One of the trials that was involved before called an interleukin-17 inhibitor that was conducted maybe about 5-7 years ago. And of the 153 patients that were in the trial with Behçet, only 2 of them come from the United States over a period of 2-year recruitment that help patients doing that. So this is a condition that clearly is very much localized to this part of the world. But it is a relapsing and remitting systemic vasculitis of unknown etiology of this aspect. The triad with this, it has intraocular inflammation as well as oral and mucosal ulceration. So the diagnosis of Behçet require, you know, major and minor criteria. So oral also is one of them with this aspect. You have seen me use the term adamantitis, Behçet disease, this aspect of there. Who is adamantitis? So, at certain point, so I have I'm privileged to lecture around different parts of the world. But at certain point, I was almost abandoned to go to Turkey because of this reason. So when we wrote our chapter on this, we look back at the history and we figure out one of the most famous things in medicine for Turkey is Behçet disease. That is the disease they claim is a Turkish disease that everybody in every presentation come from Turkish college usually has to do with Behçet in some way. So here I come, I wrote one of the major chapter in this uveitis textbook, and I re-changed it with that. And so they get really annoyed, and so they banned me for jokingly from going to Turkey. But Adamantiadis was a Greek dermatologist who actually did this. But he published his first report in 1931 in the French literature. And people don't read French, they read at that time German, because German is considered at that time very advanced in medicine. So Bechet published it later, a few years later, in the German literature. So that's why he gets his name out. But if you go back to the literature, the first type of report is Adamantiadis from Greeks. And of course, Greek and Turkish are not always good to them either. So this is another reason why they don't like to see this aspect from there. But sometimes you see the report, and if you see anything that we share in our report, we usually use the whole name out from that. But that's where the name coming from that. But of course, Bechet is much more well known from this aspect. That's what it is. We saw it yesterday. The most famous thing about this is they have a very painful, we discussed it yesterday, very painful ulcer that they really bother the patient from this. That aspect. Most common in the middle and far east along the latitude here. We see a lot of them also in this part of the world that patient travel here. So whether I'm in Japan or Korea or in this part of the world, we see a lot of Bechet that being discussed the cases as well. The Silk route that have taken people, they have also carried this disease along the way. The international study group for Bechet disease is developed, and colleagues come together to come up with different criteria. Recurrent oral ulcer, and then presented two other criteria, either the genital lesion, the skin lesion, the eye lesion, or the positive pathogen test. Okay? So here, unlike lupus, the eye is one of the findings that recognized in the minor criteria, not major. The oral is the major criteria, and then some of the minor ones, you need two of them. And so the eye is one of them from this aspect from there. So this is what we call. This picture is shown because as you can see there's a hypobion there. So this I mentioned yesterday, Bechet is, Adamantiadis Bechet is one, and then the other one is B27. Those are the two most well-known entities that give rise to hypobion, and as you can see it's there from this aspect there. The systemic manifestation, you have oral ulcer, you also have genital ulcer, you have central nervous system lesion, and hearing loss. So many of them will do aspect. But the ulcer, we ophthalmologists can easily see this ulcer. Like, if you ask the patient, he or she will volunteer the information for you because it's quite prominent, and you will be able to hear from that very well from there. With this aspect, the systemic manifestation again involve multiple organs. You have the dermatologic lesion. You also this is intrathoracic. You have cardiac, which is shown here, where you have the pericarditis, and you have the ventricular dysfunction that usually lead to the mortality. And then you also have GI manifestation as well from this aspect here, from there. So the organ manifestation, the episcleritis, the scleritis, and the keratitis present. So here, that on the differential diagnosis for scleritis. So if you see cases here where you have a significant aggressive necrotizing scleritis, that's what you want to do. By the way, this is the case of necrotizing scleritis, right? Compared to the other one that I showed before, where you call scleromalacia perforans, you can see the difference. Here, the localized area is very active. I believe one of the colleagues is talking about scleritis, correct? Or that was given already, or no? I think it's coming up today. You will see, so there's different type of scleritis. So you have anterior scleritis, you have nodular, or you have diffuse, and then you have this necrotizing scleritis, and then which is this in the picture before that is the scleromalacia perforans, where you see not so much of the redness and thing, but you see the very much melting away the sclera already. So this is on the differential diagnosis for that group there. Here, the retinal hemorrhages can exudate, like this particular case, this aspect, but the other part that they're well known for is the occlusive of the vessel. So vascular occlusion is very commonly seen in the Bechet aspect from the vitreous hemorrhage and tractional RD are also important. The dysedema and then eventually atrophy of the vessel like this, that would be very important as well. We have talked briefly about a little bit about the treatment of that. So in a country like Japan, the treatment for this, as I mentioned yesterday, is the use of a TNF alpha inhibitor, and particularly infliximab. That is the first line therapy for that. In the United States, we also using that as well too. I always use it in combination with methylprednisolone to get increased efficacy for that aspect. But this is one of those conditions that can go down very much, very quickly. And so interesting enough, when you look at clinical trial in uveitis, sometimes the clinical trial exclude patients with JAK disease for that reason. It's that, of course, it's very aggressive, and also the patient can go to flare up anytime with other organ failure. So to avoid the confounding factor, oftentimes when we design uveitis study, we try to put the shed out from that group because they're so unexpected, and sometimes we cannot withhold other treatment if they're on that aspect. Last thing we could do is relapsing polychondritis. How many people have seen RP before? No one's seen RP, so you see this. So I have had the opportunity to see some of this. So this is quite fascinating aspect from there. So what involved in RP? This is a multi-organ disease resulting in prevention of the cartilage, right? So where's the cartilage in your body? So the ear is one, what's the other thing? Let's say we look at the head part, okay? So one is the ear, where's the next part? Nose. And what's the third one? Yes, the trachea, right? So that's what you see. So those are the common parts. You see the trachea, the nose, and the nose, and then you see the ear. So those are people, and patients will complain that they have painful earlobe. So this lady here, male equal to female onset, usually 4th, 5th decade or so. This so-called McAdam criteria is when you look at the inflammation in the cartilage with the nose, the earlobe, the respiratory tract at this aspect, and you need 3 of those sites to make the diagnosis from this thing here. So the auricular manifestation is one of the most common one. So that's about 90% of patients. They come in with a painful earlobe, and they have the cartilage dryness area there, and then the nose is about 80%. So that is what. That's the side of vulnerability. So beside, here's not a trick question for you. Beside RP, relapsing polychondritis, what other disease can give you side of nose deformity like this? I'm sorry? Syphilis and one more. Leprosy you will see on the skin finding as well with this aspect more obvious. So the other thing that you will see is actually Wagner, GPA. So that's something that now did more. So if you look at the literature, that's another one that you will see the saddle deformity of the nose. So when you see this, yes, RP is on the list, but you also look at the thing of the GPA as well with this aspect here. So this is the one more case of mine that I remember too. So this is when she presented to me. This was like she was like 30 something, early 30s. She's Korean American. She presented like this. What is special about her feature? What is she wearing and things? I'm sorry? Right, so why do you think it's there? What beyond the deformity, what else, what's beneath that? Right, so underneath that, she had that tube right there. That's what she does. So she has the RP, and they have to do, what they do is they do a emergent tracheotomy for her, that keep her there because the disease is active, so at any time it can attack. So patient with that, that's how she presents. And she come up with very cleverly to cover a color like that, so that's aspect from there. So because I say this is something that obviously you can die from, so that's why they leave the tracheotomy open and you should just cover from that. Okay, so this is when you see it. Patient like this, you come and you will not forget that nose is very plastic. There are very few things that can give rise to that nose. So relapsing polychondritis, and obviously still the caterpillar infection, but the other thing is the GPA from the redness, so you will be able to see that as well from there. Okay, so you look for different signs and things, and so some of my teachers you see when you can make the diagnosis across the room. And it is true, if you walk into the room and the patient has this, you can tell right away from this aspect they have that from there. So you can see here, the ocular manifestation here is pretty high, 50% of the cases we have ocular manifestation. In addition to the very common part of relapsing polychondritis is the scleritis. That is very true. We see many of them like that. Now, here is when you do see a little bit of iridocyclitis in conjunction with the scleritis as well. And then in the eye, you will see the hemorrhages from there. It's much rarer. So the ocular manifestation of relapsing polychondritis is more of an external component with the scleritis aspect from there, from aspect. So this is my last slide here. Over the last 45, 50 minutes or so, we have covered what I thought are 6 of the more common conditions that you will see in this aspect. So we talk about lupus, we talk about sarcoid, we talk about rheumatoid arthritis, we talk about the wet GPA part, and we talk about relapsing polychondritis. So these are some of the things that certainly by no means exclusive list for this, but this is something that we see, and you're doing across your career, especially if you go into this field or you've seen many patients, you will come up with this aspect from there. And it's a very important side because you keep in mind that there are manifestations of systemic autoimmune disease in the eye. So keep that in mind. And again, even more important than that, when you see that, what do you do? So we as ophthalmologists, remember, you first and foremost, you have to believe in yourself that you're a real physician. Don't let other people say, oh, you're just an eye doctor. That's not true. So you need to make sure, that's why we go to medical school first before we become ophthalmologists. You need to be able to say, okay, when I see this, what can go wrong elsewhere and how can I help the patient? And what do you do that? Because you can help to make the practice. No other field in the that will be able to look at the eye better than us, the ophthalmologists. So the rheumatologists, the pulmonologists, they cannot see the eyes what we do. So sometimes what we see in the eye will open the window for them to be able to see it out. So use your information, share them wisely, share them appropriately, so that together, not only do we control the eye disease, but we also hopefully help the patient survive as well too. Okay, thank you. We have 2 minutes for question before Dr. comes on. Any question?
RA doesn't present as an isolated non-granulomatous AAU.
Yes.
What if it's a granulomatous AAU?
So if
think of RA?
No. So I still want to my point is that the rheumatoid arthritis usually does not present with anterior uveitis alone with this aspect from there. So you're correct. Whether it's granulomatous or non-granulomatous, I do not see it. If it's just that with the RA, in other words, patients with RA usually don't present it like that. And so how did this help with this aspect? If you have right now a patient that have just the anterior uveitis, and let's say the patient also have RA, rheumatoid arthritis, sometimes it's hard to, one of the treatment that just got approved is the adalimumab, the TNF-alpha inhibitor for that. But it's hard to make the leap to then use the TNF-alpha inhibitor to treat the uveitis if the uveitis require treatment. In other words, if the patient have anterior uveitis that is refractory, recurrent after you stop the total steroid, and if you're not managing this patient and you ask the rheumatologist to go ahead and try to treat the patient from this aspect, the rheumatologist can look at the case and say, oh, well, we just put the patient on adalimumab because the patient also have rheumatoid arthritis in this aspect. The point is that it is not really appropriate that way because you have to make the association. If the patient has rheumatoid arthritis that need the TNF-alpha inhibitor, that's one thing, then fine, you go with that. But you cannot say, let's use adalimumab to treat the uveitis in this patient who have RA because the RA caused the uveitis. That's where the connection doesn't work, and we don't have cases that really illustrate that aspect. Right. So therefore, that's sometimes when we lecture to the rheumatologist, that we want to share with them the certain aspect from there that there's no connection. So yes, the patient have RA, but the patient can also have RA and for example, syphilis for that matter, that have the uveitis. So you cannot just claim that the anterior uveitis you have is related to the rheumatoid arthritis.
Okay.
So, yes.
Can I just ask, for your sarcoid patients, how many of your patients end up having isolated ocular disease and without any systemic manifestations?
Yes.
Or negative ACE?
Yes. So that's the big one. So I mentioned about this limited condition thing. So when I was in Boston, we look at the series up there, and it's about 3 to 5% of the cases of sarcoid that will present initially with just the eye finding alone, and then 5 years into the things, 5, 6 years, something like 7 years, that when they evolve into systemic finding. So that's what I say. You use your judgment, clinical judgment. You do your best to work up the patient. If you work up the patient and the thing is negative, but it looks very much just like this, not with granulomatous and the recurrent nature and that's that, and you already rule out the infectious cause like TB and so on, you can treat the patient at though this is a suspected sarcoid or ocular sarcoid, and you can watch for that, and that will change. Again, repeat the evaluation after a few years.
And same thing for your ankle-related vasculitis like GPA. How many of them actually come with just ocular disease without any systemic manifestations? I mean, do you always see, just out of curiosity, I mean,
so definitely, we see often more that we see a patient coming with the disease already and then have the eye finding. So that's the easy part. So we see that. The cases that I've seen in the, again, these are less than 10% that will just have the eye finding ahead. Yesterday I showed you the case of lupus that was that was 3 cases. I have a couple more cases that which is the eye, but it's also depend on where you practice as well. I myself always been as a tertiary center, so usually the cases are difficult, they send it to us and we work them up from there. But in general, if you in an outside practice, usually the patient will come in for you with the diagnosis already there. But keep this in mind that they do not always come like that, and that's the reason why we enjoy this field, because we get a chance to work the patient up and evaluate the patient. But usually in all the series that we look at, it's less than 10% of the time that they present first with the ocular finding and no systemic disease yet, and then you work them up for whether be it lupus or be it wag-limited. But on the other hand, if the anchor level, that when you see the systemic marker, like for example, anchor for wag, the complement level for lupus, for example, when you see them become really abnormal, like in the case of complement we talked about yesterday, when the complement level is very low or when the anchor is high, you know that's unlikely that it's just the eye only. It may not manifest it yet, but the disease is coming very shortly. So then you watch for that. And for that matter, like I mentioned yesterday, when you treat them, you also should be able to see the reversal. So when you treat patients with high anchor, you treat them, one of the response you will see will be the anchor will start to go down again.
But and just to check with regards to the ankle issue and patients with scleritis, because sometimes I find that some of my patients with scleritis, once they get better, the sclera sort of has this slightly vascularized appearance. They have no pain. The eye is not very red, but it just looks a little bit, there's a tinge of red there. So how do you track subclinical scleritis? I mean, how often when do you repeat the anchor, when do you repeat the complements? Because it takes some time for it to come down.
Yeah, so the thing that's an excellent question too. So I don't necessarily treat the anchor, I don't follow anchor all the time unless there's something elevated for that. And we do have the patient that. So one of the studies that we are working at Stanford is to actually look at the vessel density of those patients using anti-second OCT to look at the vessel density of those patients. And we are believing that we're able to hopefully create an index to figure out where is the disease heading between the inactive stage and the active stage, and from the vessel density, because in cases when you have active scleritis, it's usually an increased level of that, and to measure that, just in the case that you described, where there's just a little bit of redness and the patient really do not have significant pain, but he or she say, I do feel it, but I can sleep through it, for example. So that we were looking for different indexes for that.
Yes. To SLE, in cases like ocular neuritis or other retinal manifestation, how do you tell whether it's a immune-mediated or some vascular occlusion is actually causing the manifestation? Because in terms of prognosis and the management or treatment is pretty different.
Yeah. So the question there is when you have a occasion like that, whether you have just occlusive or you actually have circulating complexes, right?
Yeah.
Okay. So one of the serologic testing, I'm not sure if it's available for other hospitals. You can look for immune complexes in blood that you can test for it, the level from there. So that is being done from this aspect. But you're correct, sometimes it's harder because whether it's circulating there or whether it's occluding the vessel, then you cannot tell. So you look at the situation, you look at some other, when they have immune complexes circulating around like this, other marker, for example, in the case of lupus, the complement level is also, they call complement consuming disease, that aspect. So you would expect to see low. When you see something like this, then you probably suspect that there are circulating immune complexes that are moving around. Because again, like I said, we should utilize as much as we can other marker that will help us as ophthalmologists to make the decision on this thing. The eye, we look at it, but that's what the whole body, so we can look for all different things to see whether it makes sense to do that. Great.
Right?
Yes, sir.
Last, this is a technical question. So in my institution, we have this thing called an NCAR screen. And
NCAR
we have
screen.
the NP-PR3 and the NP-MPO. But we have the C-anchor and P-anchor tests specifically. So
You don't have, right?
Is there a difference between the NP and
No, I think so. It's dependent on lab, but the equivalent aspect from it. So you correct. So myoperoxidase is another one. And that's the proven there. It's the same range of spectrum. It's just the matter of nomenclature that people use from there. But definitely. Yes.
To evaluate the sarcoidosis, we need to investigate first the serum A's and also imaging, right? So for imaging, if the chest X-ray is normal, then we should proceed with CT, high resolution
So
CT.
if you have CT have a lot of radiation, correct, for the body. So you make the decision. You say, or should we go ahead and do that? So you need to have some kind of suspicion to move forward with that. If you see some sign on a chest X-ray that's a little bit suspicious, or you see mildly elevated or upper normal of ACE or lysozyme or whatever not, or you see something that's very classic from that. So you justify, and I fully agree, sometimes things are missed on chest X-ray and found on chest CT. So we are not saying that you always have to see something first in the chest X-ray to move forward with the chest CT. But because the chest CT has its own risk as well with the radiation for the patient, you ask the question, do I have enough clinical evidence or do I have enough clinical suspicion to move forward with that for the evaluation? If the answer is yes, then by all means that's very justified. But if you just fishing out, like you don't see anything, but you just want to go ahead and do that, then actually for that you should order like a helium scan to do that. That's a little bit less exposed to the radiation.
In compared with the gallium and also the PET scan.
Yes, that's
which is
correct.
More superior.
Yes, yes.
Which
So,
one is more superior?
so
Or gallium?
the helium scan is the gallium scan is a little bit better for that. To do that aspect, when you order a gallium scan, that will help with this aspect from there. And there's less of the radiation going on. Of course, a little bit more expensive too. Great. Yes, I have the hand in the back said I need to get out, so I will get out here before. So Professor Gupta, I can share with you. Hold on.